Good morning to all. Today we are discussing about the disorders of cornea, that is keratitis, corneal ulcer, and its treatment as corneal transplantation or keratoplasty. So keratitis is the inflammation of the cornea, as you all know. So the anatomy related to corneal keratitis, cornea is divided into 5 layers: epithelium, Bowman's layer, stroma, Descemet's membrane, and endothelium. So the layers of the cornea, here you can see the diagram. Definition: keratitis is the inflammation of the cornea and it is often triggered by infectious bacteria, virus, fungi, or injuries like a scratch. So here you can see in this diagram, there will be inflammation of cornea, redness of the skin surrounding the eyes, and you can see the bloodshot eye. So types of keratitis according to the layers of the cornea involved: superficial and deep. Superficial keratitis only the outermost layers of the epithelium, and deep affects the intermediate layers. So in superficial keratitis, which affects only the outermost layers, and deep keratitis affects the intermediate layers, the stroma. That superficial keratitis, there is actinic keratitis, filamentary keratitis, and exposure keratitis. So deep keratitis involves the stroma. There is interstitial keratitis, which is primarily caused by immune response to underlying systemic infections like syphilis or tuberculosis. Deep stromal ulcers, they are mainly microbial infections like bacteria or fungi, where the infection goes into the deep corneal layers. Then herpetic stromal keratitis due to herpes simplex virus. Then types of keratitis, here you can see a healthy cornea. Here you can see the bacterial keratitis, fungal aspergillus, fungal fusarium keratitis, and fungal candida. There are two types mainly according to the pathogens. Infectious keratitis, if the pathogens are involved, like bacterial, viral, fungal. So bacterial associated with the contact lens wearers who do not clean the cases properly or sleep with the lens. Then viral can be due to herpes simplex virus, fungal and parasitic like ascendamema, often found in contaminated water or soil. A non-infectious keratitis by physical injury, environmental factors, or contact lens overuse. Then infectious keratitis can be adenoviral, herpetic, bacterial, fungal, or ascendameba. Causes: bacterial, viral, fungal, and parasitic, and non-infectious. So here you can see the diagrammatic presentation. Weakened immune system, dry eye syndrome, infectious causes. Then improper contact lens and care of use of lens. Foreign objects in the eye scratches, and intense light or photokeratitis due to exposure to ultraviolet light. What causes keratitis? Already we have discussed: weakened immune system, dry eye syndrome, infectious causes, intense sunlight, photokeratitis, and eye injuries, and foreign objects in the eye. Pathophysiology: this keratitis that's caused by invasion of pathogens, bacteria, virus, or fungi that cause presence of pathogens in the tissues, leads to inflammation, and multiplication of bacteria again leads to infection and symptoms like discomfort of the eye, watery eyes, and redness of the eye. And main symptoms are common symptoms: eye redness, pain, or feeling that something is stuck inside the eye, watery eyes or abnormal discharge, sensitivity to light or photophobia, and blurred vision. So here you can see the healthy eye and the keratitis eye, which is symptoms: red eyes, profuse tearing, photophobia, corneal clouding, and intense pain. The symptoms: corneal inflammation, discharge will be the redness in the skin. Investigations: physical examination and history taking, slit lamp examination, fluorescein staining, polymerase chain reaction, and in vivo confocal microscopy. Slit examination shows it's a diagnostic tool using magnification and bright light to evaluate the exact location, size, and depth of the corneal infiltrates or ulcers. Then fluorescein staining is a gold standard for infectious keratitis to find out what organism. Smear microscopy and polymerase chain reaction to find out to detect the direct DNA, herpes simplex or specific parasites when cultures are negative. Then in vivo confocal and non-invasive imaging techniques that provides the visualization of fungal filaments or acanthamiva cyst within the cornea. Then treatment bacterial will give antibiotics like fluoroquinolones and eye drops, vancomycin, tobramycin, viral antiviral eye drops, Clovir, acyclovir tablets, fungal eye drops, antifungal eye drops like natamycin and oral antifungal medicines. Parasitic acanthamiva due to that will give maybe or antiparasitic drops. Non-infectious, we should tell the patient to manage with the preservative-free artificial tears, trusting the eyes, and to avoid allergic factors. So here the pathogenic organisms, according to the organisms, we will give the drugs. If it's bacteria, we will give antibacterial drugs. It's fungal, antifungal agents, antivirus agents for virus infection, anti-acanthamiba drugs for amoeba. Keratitis, you can also give antibiofilm drugs, immunomodulatory drugs. Surgical management, corneal gluing, amniotic membrane transplantation, corneal cross-linking, therapeutic keratoplasty and corneal transplant. Corneal, next topic is corneal ulcer. So corneal ulcer is an open sore on the clear outer layer of your cornea. It's usually caused by an infection, bacteria, virus, fungi or parasites or physical trauma. And it requires medical attention. If treated, untreated, you will get blind. You lose your vision and you will become blind. So corneal ulcer often resulting from keratitis is an inflammation, or more seriously you can see the epithelial layer is involved in the involvement of the corneal stroma also. So corneal ulcer may be defined as the discontinuation in the normal epithelial layer of the cornea associated with necrosis of the surrounding tissue of the cornea. So keratitis is the inflammation of the cornea, but corneal ulcer is an open sore that develops as a result of this inflammation of infection. So there is a difference between keratitis and corneal ulcer. So keratitis is the inflammation of the cornea, but corneal ulcer is an open sore that develops on it as a result of this inflammation or infection. Both are medical emergencies that require medical attention. Otherwise, it can lead to blindness or vision loss. So causes: contact lens misuse, infections, bacterial, pseudomonas, virus like herpes simplex virus or cold sores, fungal or parasitic by acanthamiba. Eye trauma, eyelid disorders like Bell's palsy. You can see the prevent eyes from fully closing leads to severe dryness of the eyes and vulnerability to ulcer. Immune conditions, autoimmune diseases or severe dry eyes. So these are the risk factors. Some risk factors: eye infection, failure to wear eye protection, dry eyes, failure to treat the conjunctivitis, exposure to UV light, wearing contact lens, misusing contact lenses, prior corneal abrasion or eye injury, and prior corneal ulcer. Symptoms are watery discharge, eye contact, severe eye pain or ocular pain, photophobia, blurred vision, and red eyes. Surgical management, you can use corneal gluing. It's one treatment where you are using the cyanoacrylate glue or fibrin glue, but cyanoacrylate glue is performed more because it has advantage. First, bacteria cannot grow in it and it's not a hospitable environment for microbes. Second, it's a bit irritating, which actually helps in these cases. And this cyanoacrylate glue promotes neovascularization in the cornea, which can be beneficial in the periphery. So while fibrin glue is more commonly used, but cyanoacrylate glue is performed because it is stronger. Surgical management, again, amniotic membrane transplantation is done. So when a large central perforation, glue is not ideal. So we have to do this amniotic membrane transplantation. So here you can see the non-healing corneal defect with melting, stacked and covered with amnion. This sick cornea is totally covered with amnion and healing epithelial cells grow on the amnion. That is amniotic membrane transplant. Then corneal cross-linking. That is the procedure in which we are stiffening and strengthening the cornea using ultraviolet light and riboflavin, vitamin B2 eye drops. So epithelium removal is done. That is the outer layer of the cornea is gently removed to allow better absorption of the medication. Then riboflavin saturation. Liquid riboflavin drops are applied to the cornea continuously for about 10 to 30 minutes. And UV light activation. So a focus beam of ultraviolet light is shown onto the eye for roughly 30 minutes. The UV light activates the riboflavin, creating new chemical bonds between collagen fibers to strengthen the tissue. And bandage lens. A temporarily bandage contact lens is placed over the eye to aid the healing. Then therapeutic keratoplasty, that is a corneal transplantation. In this, the surgeon uses a specialized instrument to remove the full thickness of the damaged or opaque cornea, and then a perfectly sized healthy cornea from a deceased donor is placed on the eye. The new donor cornea is secured into place using very fine sutures and stitches that will remain for months to years. Complications of keratitis are corneal ulcers and perforation, severe scarring and vision loss, irregular astigmatism, intraocular infections, secondary glaucoma, and recurrent infections. Nursing management, administration of therapeutics, strict adherence to the prescribed medication schedule, then correct installation of the eye drops, teach proper hand hygiene and sterile technique for applying eye drops to prevent cross contamination, gently pull down the lower lid to create a pocket and ensure the dropper tip never touches the eye or surrounding tissues. Then pain management by administering prescribed analgesics and cycloplegic eye drops to paralyze the ciliary muscles, reducing the painful spasms. Then environmental control by managing photophobia by dimming the room lights or having patient wear dark sunglasses. Hygiene, frequently and gently cleaning the eyes of the dried discharge using sterile saline wipes or bottle balls. Health education is important here. Contact lens cessation. Patient instruct the patient to immediately stop wearing contact lens and to discard their current lens. And red flags, educate the patient to immediately report the signs of worsening infections such as increased eye pain or ocular pain, blurred vision, discharge or lid swelling. Prevention of complications. That is steroid caution. Monitor closely for the administration of corticosteroids. While they reduce inflammation, they can worsen the fungal or viral keratitis and must be used with caution only under strict ophthalmology oversight. And surgical preparation, sometimes we have to post the patient for therapeutic keratoplasty or corneal transplant. So next topic is about corneal transplantation or keratoplasty. Keratoplasty or corneal transplantation replaces the damaged or diseased cornea with healthy donor tissue to restore the vision, to relieve the pain or treat the severe infections. It's commonly performed in keratoconus fuchs dystrophy or corneal scarring. The types of transplantation: penetrating keratoplasty, in that a full thickness transplant replaces the entire cornea. Endothelial keratoplasty, a partial thickness procedure, replaces only the innermost layer. It is usually used for fuchs dystrophy. Deep anterior lamellar keratoplasty replaces the front and middle layers, leaving the innermost lining intact. So these are the pictures showing the different methods of keratoplasty. Penetrating lamellar endothelial keratoplasty. Penetrating keratoplasty is a full thickness corneal transplantation. The surgeon removes the center part of the diseased cornea, and after removing it, it replaced with a healthy piece of donor cornea. Endothelial keratoplasty, it's used to remove the back tissues, the innermost layer of the corneal layers. That is the endothelium and Descemet membrane. There are two types of endothelial keratoplasty: Descemet stripping endothelial keratoplasty, DSEK, and donor corneal tissues replace 1/3 of the cornea, that is in Descemet membrane endothelial keratoplasty or DMEK. The thinner layer of the donor's cornea is used to replace the diseased corneal tissues. Lamellar keratoplasty, this is a surgical procedure in which The outer layer of the damaged cornea is replaced by the general donor corneal tissue. It is sometimes known as deep anterior lamellar keratoplasty or DALK, or partial thickness corneal transplant. It's commonly used for the treatment of bulging cornea disease, that is the keratoconus. In keratoconus, we are doing lamellar keratoplasty. So these are the types of corneal grafts used today: full thickness or partial thickness. Indications of corneal transplantation or keratoplasty is Fuchs dystrophy and bullous keratopathy, in which damage or loss of the innermost corneal cells endothelium causes painful swelling, edema, and cloudy vision. In keratoconus, a progressive thinning and bulging of the cornea into the cone shape, which distorts vision beyond the correction capability of specialized contact lens. Then corneal scarring and ulcers, dense opacities or structural melts resulting from severe bacterial, fungal, or viral infections like herpes simplex keratitis. Keratitis also is an indication for corneal transplantation. Chemical burns or trauma and severe physical damage or caustic chemical exposure that irreversibly alters the ocular surface. Then failed previous corneal transplants or rejection. Then contraindications of this keratoplasty or corneal transplantation is severe ocular surface disease, irreparable retinal or optic nerve damage, uncontrolled glaucoma, active infection or inflammation, uncontrolled systemic infections, eyelid abnormality, severe lid malposition or blinking issues, and severe psychiatric or neurological disorders, impaired healing, or uncontrolled diabetes mellitus. Procedure: penetrating keratoplasty, the entire cornea is replaced. Surgeon removes the button-sized disc of the damaged cornea and sews the maturing donor cornea in place using fine sutures. A complete vision restoration takes place a year or longer, and this method carries a slightly higher risk of tissue rejection. This is the thing you can see. First, disease or injured cornea is removed, or then clear donor cornea is sutured in place. Then endothelial keratoplasty, that is partial thickness transplant. The innermost layers of the cornea, commonly used for endothelial disorders like Fuchs dystrophy. The surgeon removes only the diseased inner layer through a tiny incision and inserts a microscopic disc of donor tissue. An air bubble is used to hold the new layer in place instead of numerous stitches. Recovery is faster and lower rejection risk. Then anterior lamellar keratoplasty or ALK, partial thickness transplant that replaces the front and middle layers of the cornea while leaving the healthy innermost endothelial layer intact. This is usually done in conditions like keratoconus. The surgeon removes the damaged front layers and stitches the healthy donor tissue on top. Primary complications of keratoplasty or corneal transplantations are glaucoma, infection, graft rejection, graft failure or detachment, astigmatism and refractive errors, and retinal complications. Preoperative care, the medical clearance, medication review, starting eye drops or antibiotics or anti-inflammatory drugs. Arrange transportation, because this is done in local anesthesia and the patient cannot drive, so mild sedation will be there. So somebody has to be there for taking this patient from the hospital. Hygiene and preparation: do not wear makeup, lotions, creams or perfume on the day of surgery. Leave all jewelry and valuables at home. Fasting: follow your surgeon's instructions regarding eating and drinking. Typically avoid food after midnight. Then post-operative expectations: immediate aftercare, antibiotics and steroid eye drops to prevent infection and help your body to accept the new tissue. Wear a protective eye shield, especially while sleeping. Regular follow-up appointments are required over several months or even years. Stitches from a full thickness transplant are typically removed or at later clinical use. So nursing care, nursing diagnosis: first one is risk for infection related to surgical incisions, presence of sutures and use of immunocompressive eye drops. Second nursing diagnosis is risk for injury related to increased intraocular pressure, accidental trauma or rubbing the surgical line. Third is deficient knowledge related to post-operative self-care, activity restrictions and recognizing signs of graft rejection. So immediate post-operative care: positioning the patient, especially on their back or the non-operative side, to reduce intraocular pressure and help the new tissue settling. Eye protection: ensure the protective eye shield is securely taped over the operated operated eye before the patient leaves the recovery. And pain management, assess for pain, and if there is pain, we have to give the give the analgesics, and because the severe pain will indicate the dangerously elevated intraocular pressure or surgical complications. Then medication, eye drops, especially antibiotics to prevent infection, and corticosteroids or immunosuppressant to prevent graft rejection. Ensure strict hygiene before touching the eye or dropper. Systemic medications, administer anti-nausea medicines to prevent postoperative vomiting because it will cause straining and increases the intraocular. Health education, especially contact your eye surgeon immediately if you experience any of the following symptoms: the sudden or significant loss of vision, new worsening eye pain or ocular pain, initially red or bloodshot eyes, increased sensitivity to light or photophobia. So activity restrictions, instruct the patient to avoid bending at the waist or heavy lifting over 10 kg and straining for at least 3 to 4 weeks. Eye protection by wearing eye shield, and hygiene while taking care of the eyes. They have to show the patients how to gently clean the sticky eyes with cool boiled water and sterile cotton wool. Keep water out of the eyes during showering for at least 1 month. Warning signs, you have to educate the patient about the warning signs of, or report the signs of corneal transplant rejection, including persistent redness, sudden blurry vision, light sensitivity, and ocular pain or eye pain. Follow-up, emphasize the necessity of attending the follow-up appointments with ophthalmologist. So conclusion, corneal transplantation is a highly successful, widely performed slight restoring procedure with modern techniques like partial thickness lamellar graft and DMEK and BSEK. Recovery is faster, rejection rates are significantly lower, while it resolves severe vision loss from conditions like keratoconus or corneal scarring. Patients still require long-term care and monitored for potential complications like graft rejection or glaucoma. So today we have seen the disorders of cornea, keratitis, corneal ulcers, and the treatment corneal transplantation or keratoplasty. Thank you. Thank you so much.